day, and welcome to the Pancreatic Cancer Action Network's webinar, Treatment Approaches for Pancreatic Cancer, presented in recognition of National Pancreatic Cancer Clinical Trials Awareness Month. The Pancreatic Cancer Action Network recommends that all patients consider clinical trials when exploring treatment options. Clinical trials may be the best option for the patient, and they are vital to making treatment progress and improving outcomes for patients. January is a time to raise awareness about the importance of clinical trial participation. Thank you for participating in this webinar to learn more. This webinar is scheduled for 60 minutes and includes a presentation followed by a Q&A session. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. We encourage you to submit written questions at any time during the presentation using the QA panel located in the bottom right of your screen. After typing your questions in the space at the bottom, hit the Send button, and please be sure to direct your questions towards all panelists in the drop-down menu. Your questions will not be seen by other members of the audience and will be addressed, time permitting, towards the end of our session. Dr. Hedy Kindler is a professor of medicine and the medical director, gastrointestinal oncology at University of Chicago Medicine. She is an internationally recognized cancer expert who specializes in the medical treatment of pancreatic cancer and malignant mesothelioma. Her research focuses on the investigation of novel agents for the treatment of these cancers, and she designs and leads many innovative clinical trials for patients with these diseases. Dr. Kindler, I now turn the presentation over to you.
Thank you so much, everyone. It's really a pleasure to be able to speak with all of you today about treatment approaches for pancreatic cancer, and I look forward to your questions at the end. Pancreatic cancer is a challenging disease. As we know, it has the lowest survival of any solid tumor, and that's partly because it is rarely diagnosed early when it might be curable. There are no effective screening tests for this disease, and its vague early symptoms can mimic other diseases. There are many nearby blood vessels which allow it to spread quickly. In addition, it often doesn't respond to treatment. Pancreas cancer is resistant to many drugs, in part because the dense stroma around the tumor acts as a barrier to protect the cancer cells from chemotherapy. And we don't understand its biology well enough to develop more effective drugs, and much more research is needed. Because of these reasons, within this decade, pancreas cancer is projected to become the second leading cause of cancer death in the United States. Who gets this disease? It's pretty evenly split by gender in terms of the incidence and the deaths. Most patients are between the age of 65 and 80 at diagnosis, and in this country, African Americans are more likely to develop the disease than Caucasians. The risk factors include smoking, which is attributed for about 30% of all cases. Other causes include pancreatitis, increasing age, diet, diabetes, and family history. Indeed, there are a number of familial or inherited syndromes that cause pancreatic cancer, and some of them actually enable us to target specific treatments if we know what syndrome it is. Among them, the hereditary breast ovarian syndrome, BRCA1 and 2. The most common symptoms at diagnosis include pain, yellow jaundice, weight loss, decreased appetite, depression, which often can predate knowing about pancreas cancer even 6 months before, nausea, vomiting, blood clots, itching, tiredness, and new onset diabetes within the prior 6 months to even 2 years before the diagnosis of pancreas cancer. Now, if it looks like pancreas cancer on a CAT scan, why do we need a biopsy? Because knowing the pathologic type of pancreas cancer will determine our treatment options. And today I'm going to focus exclusively on adenocarcinoma, which makes up the vast majority of pancreatic cancers. And in that slide, I've shown you the prominent stromal reaction in the classical pancreatic adenocarcinoma. What is the stage of a pancreas cancer? Patients often ask that. It refers to the extent of the disease at diagnosis, and it's one of the most important factors for determining treatment options and determining a patient's prognosis. We determine the stage based on a CT scan, endoscopic ultrasound, a biopsy, and sometimes a physical exam. And sometimes we need to determine it at surgery. The classic staging system is the TNM staging system, a standard way to determine how much a cancer has spread. And the three elements are T, which is the size, N, which is the lymph nodes, and M, which indicates spread to other organs. The most common sites of spread are the liver, the lungs, or the abdominal cavity, also known as the peritoneum. Now, this is how a doctor thinks about TNM staging, but you as a patient don't necessarily care if you are a T1, N1, M0, stage 2B. What you care about is real-world staging and how it impacts your treatment options. And I've divided them on this slide into resectable, able to be removed with surgery, and unresectable. In the resectable category, we have those who are fully resectable. The cancer can be removed with surgery, and the treatment is surgery followed by chemotherapy. Then there are those who are borderline resectable. Here, the tumor is partly wrapped around blood vessels. It might or might not be removable after chemotherapy and radiation. And so the treatment is chemo, radiation, then usually a CT scan, and if it looks like it's removable, we'd remove it. And then there are those that are unresectable, which can be either locally advanced or metastatic. The locally advanced tumor cannot be removed, usually because it's wrapped around blood vessels, but it also has not spread. And here we give chemotherapy and sometimes radiation. The metastatic disease has spread to other organs, again, usually the liver, the lung, and the peritoneum, and here the treatment is chemotherapy. So let's talk about resectable pancreas cancer. You'll see the tumor in pink and the blood vessel in red. Here we see no distant spread and the tumor which does not wrap around key blood vessels. The standard treatment here is surgery, and the most common one is called a Whipple surgery, otherwise known as a radical pancreaticoduodenectomy. Other surgical options include a Whipple with a pylorus-preserving procedure or a distal or total pancreatectomy. Less than 15% of patients have resectable disease at diagnosis. And the goal here is to remove all of the cancer, what's called an R0 or an R1 resection. If you can't remove it all, you don't operate. This is not a tumor where we want to go in and remove 80% of the disease. We want to remove absolutely all of it. And then we give post-operative, or what doctors refer to as adjuvant treatment, which is standardly 6 months of chemotherapy with gemcitabine or 5-FU, and sometimes radiation is given, though this is increasingly controversial. This illustrates what a Whipple procedure is and how much rerouting your surgeon needs to do. And this is an approach where the surgeon really matters. High-volume institutions with high-volume surgeons, in other words, those who do a lot of this procedure, live longer and have fewer surgical complications and have a lower risk of death. What about borderline resectable? Well, here I've shown you the tumor that is partially encasing the superior mesenteric artery, a very important blood vessel. When the cancer is partly wrapped around a key blood vessel, complete removal is highly unlikely. So we give what's called neoadjuvant or preoperative chemotherapy and usually radiation to maximize the chance of completely removing the tumor by shrinking it first. And using the new, more active chemotherapy regimens that I'll talk to you about in a few minutes, these are Folfirinox and Gemcitabine and Nab-paclitaxel, we may be able to improve the chance of removing these borderline tumors. There are still a few things we don't know about these. Which is the best chemotherapy regimen for borderline pancreas cancer? And how long before surgery should we give it? We also don't fully know what the best role for radiation is in this setting. Here is an unresectable, locally advanced tumor. Here, the tumor fully surrounds the superior mesenteric artery. No matter how much chemotherapy you give to try to shrink the tumor, it's still wrapped around that artery. You still can't remove it safely. Now, with pancreatic cancer, just because you get it all at surgery doesn't mean you're done with treatment, because unfortunately most pancreatic cancers will come back after surgery. The goal of postoperative, or what we refer to as adjuvant chemotherapy, is to prevent the cancer from coming back, or to at least delay it from coming back. Because once it returns, it is generally no longer considered curable. Where does it come back when it comes back? That depends upon how long it takes for it to come back. So within the first 2 years, the most common site of disease is the liver. But over time, other sites predominate, such that at 5 or at 7 years, when it's really uncommon for the disease to come back, it's more likely to come back in the lung. But if it hasn't come back in the first 3 years, it's far less likely to return. And that's why we survey patients with CAT scans more frequently in the beginning. What can predict if a cancer is more or less likely to come back? Well, some of what we refer to as poor prognostic factors include the large tumor size, what we refer to as a high T stage, poorly differentiated tumors, tumors that don't look like the normal cells they came from, positive lymph nodes, some believe a positive resection margin, and then a high CA19-9, the tumor marker, if it's high before surgery, if it's still high after surgery, and if it doesn't decline after surgery. Now, we give 6 months of gemcitabine chemotherapy after surgery because of the results from this randomized phase 3 trial called CONCO-001, in which patients who received surgery were randomized to 6 months of gemcitabine or to observation. This plot shows what we call disease-free survival, how long it takes for the cancer to come back if it's going to. And what you can see is that it takes about twice as long for the cancer to return if it's going to in patients who receive gemcitabine. That's what we refer to as disease-free survival. This plot shows you the overall survival, and here we can see that gemcitabine not only improves overall survival in those patients who receive it, but it nearly doubles the chance of cure at 5 years. So based upon this study, we know that postoperative gemcitabine improves both disease-free and overall survival compared to observation. It's associated with more than twice the rate of 5-year survival. It holds for all stages of pancreas cancer, from the earliest to the more advanced that are removed, and whether or not margins are positive, and it supports the use of this drug as a community standard. It is what we refer to as our best level 1 evidence. Ongoing clinical trials address several additional unanswered questions regarding adjuvant chemotherapy and radiation. The first question is whether radiation is beneficial in this setting and whether it is necessary. We just don't know. It's actually a very complex discussion, and there are a number of trials over the years that are pro and con for radiation, so we really need to be evaluating it in clinical trials. With regards to chemotherapy, we need to know whether the newer regimens for advanced disease are also better in the adjuvant setting. And now the issue of timing has come up. We're wondering whether it is better to give chemotherapy before surgery to perhaps prevent metastatic disease rather than after surgery. So all of these are questions for clinical trials that are ongoing. For example, to evaluate the role of radiation after surgery, the international study RTOG 0848 gives everybody 5 months of gemcitabine and randomizes patients then to either further gemcitabine or gemcitabine followed by radiation. Hopefully this question will answer the question about whether radiation adds anything to chemotherapy. In terms of incorporating the newer regimens into post-surgical therapy, this large study gives patients the surgery and then either gemcitabine or gemcitabine plus nab-paclitaxel or Abraxane. This European and Canadian study looks at gemcitabine versus Folfirinox in the post-surgical setting. And this study, which we're doing at the University of Chicago and many other centers are doing as well, evaluates the role of the newer chemotherapy before surgery to see if we can eradicate micrometastatic disease by giving a stronger chemotherapy before and after surgery. Again, all of these approaches are experimental. We don't know if they're better, but they clearly deserve evaluation. So to summarize, for adjuvant therapy for pancreas cancer, our options increasingly include chemotherapy alone. There is some European data that supports 5-FU-leucovorin, and certainly for a patient who cannot tolerate gemcitabine, that is a reasonable option. We have very strong evidence supporting adjuvant gemcitabine to improve disease-free and overall survival. The relative contribution of chemotherapy versus chemoradiation remains unanswered, and the role of the newer regimens, Folfirinox and Nab-paclitaxel, is still unknown. Moving on to locally advanced pancreas cancer, this is a distinct clinical entity in which the disease has not spread, but it cannot be removed, usually due to involvement of the blood vessels the tumor is surrounding. This is about a third of pancreas cancer patients have locally advanced disease. And in many patients, the biology and the outcomes are different than in those patients in whom the disease presents already spread or metastatic. Here, the role of radiation is also controversial. We know that it controls pain well, although it can be difficult to tolerate. The side effects include nausea, vomiting, and fatigue. A recent European study called the LAPO-7 trial suggested that radiation might not improve survival, although the data is not fully analyzed. We also don't know if we're going to give radiation, what is the optimal timing, and I will explain. Up to 1/3 of patients with locally advanced disease will develop metastatic disease within the first few months of starting chemotherapy. Because of this, many physicians will give chemotherapy first before radiation, with the goal of trying to eradicate occult micrometastatic disease, sparing patients who develop early metastatic disease from the side effects of radiation and limiting radiation to patients whose tumors are well controlled with chemotherapy. This retrospective analysis from France illustrates this issue. Here, patients received chemotherapy for at least 3 months, and right on schedule, 1/3 of them developed metastatic disease during the chemotherapy. It was the choice of the investigators whether they wanted to give chemoradiation or continue chemotherapy. This introduces a selection bias because a doc may want to give the chemoradiation to the healthier patient and just the chemo to someone who isn't as strong. But here we can see that those patients who received chemoradiation did have their cancer controlled for longer, and they lived longer than those who just got chemo. This was hypothesis generating. It was intriguing, and it deserved further evaluation. And that led to this study, the LAP-07 trial, in which patients got chemotherapy either with gemcitabine or gemcitabine plus Tarceva, also known as erlotinib. And they were then randomized to either continue the chemo or to add in radiation. This is a busy slide, but to focus on the fact here that gemcitabine alone appeared to have a longer overall survival than those who received chemoradiation or erlotinib. And so the authors of this study concluded that for them, the standard of care should remain simply chemotherapy, although chemoradiation could be an option. Now, the study hasn't been fully analyzed, so we don't fully know all of the reasons why these results, which seem a bit counterintuitive. Is it that chemoradiation is not superior to continuing chemo? Perhaps the radiation given was simply inadequate. Perhaps the chemotherapy needed to be stronger or different. Or maybe only a subset of patients could benefit, and we need to identify a biomarker that might tell us which patients should and which patients should not get radiation. And all of these are questions in ongoing clinical trials. Moving on to metastatic pancreas cancer. This is disease which is spread, usually to the liver, lungs, or abdominal cavity. Here, the goal of chemotherapy for metastatic pancreas cancer is palliative. It is to shrink or stabilize disease, to improve or prevent symptoms, and to prolong survival. Historically, there's been a long-standing, well-deserved therapeutic nihilism regarding chemotherapy for metastatic pancreas cancer, with countless trials over several decades, many drugs and combinations tested, and minimal to no activity observed. But it's 2015, and I'm happy to report that this dismal outlook has changed, because now we do have choices, and I'm going to focus on these four options: gemcitabine, gemerlotinib, Nab-paclitaxel, and Folfirinox. Let's look at the key milestones in the development of new drugs for pancreas cancer. Before 1996 were the Dark Ages, and nothing worked. And then in 1996 came the approval of gemcitabine. For the next 10 years, many agents were tested. No drug or drug combination appeared better than gemcitabine until 2005, when erlotinib, or Tarceva, was approved based on a study that showed a modest improvement in survival. For the next 5 years, more drugs were tested, many more negative trials, until Folfirinox in 2010 and Nab-paclitaxel in 2012. So we've really made some progress since the Dark Ages, when the median response rate used to be 0 and median survival was very brief. The drug gemcitabine has a genuine but modest impact on survival and quality of life in this disease. It doesn't shrink tumors very well, but it does help people live longer, and even more importantly, we give gemcitabine because it produces what we call a clinical benefit. It improves quality of life. It stabilizes weight, it improves pain, and what doctors refer to as performance status, or one's general overall function. So placing this drug in context, it has been the cornerstone of pancreatic cancer chemotherapy for many years. While it has a minimal response rate, it does achieve a statistically significant, though modest, improvement in survival with minimal side effects. It improves pain and performance status and stabilizes weight. There is no predictive biomarker that tells us which patient is more likely to respond than another. So who is the right patient for gemcitabine? Well, either the older patient with a poor functional status or the patient who doesn't want to experience chemotherapy side effects but does have symptoms from their cancer. But we should be able to do better than this. So how did we determine if there were any other drugs that work better than gemcitabine? Well, until recently, the most common designs for randomized trials in pancreatic cancer patients were either drug X versus gemcitabine or new drug X plus gemcitabine versus gemcitabine. And even though gemcitabine doesn't work very well, it still, unfortunately, works better than most other drugs. So that in phase 3 trials of drug X versus gem usually wins by a lot. Gemcitabine also makes sick people feel better, and it's less toxic than most other drugs or drug combinations. But 2 drugs should work better than 1, so why not add other drugs to gemcitabine? Unfortunately, in phase 3 trials of drug X plus gem versus gem, there's usually greater toxicity with the combination, but as these overlapping curves show you, no survival difference. Unfortunately, most of the time, more is not better. Most combination treatments increase side effects, but don't improve survival. And this pattern of superimposable survival curves was until recently the most common outcome of randomized pancreas cancer trials. And despite the promising activity of many new drug combinations in what we refer to as phase 2 studies, they just didn't improve survival in phase 3 randomized trials. This bleak outlook finally changed in 2005 with a Canadian trial, the NCIC PA3 trial, which demonstrated a modest improvement in survival for gemcitabine plus erlotinib, otherwise known as Tarceva. What is Tarceva? It's what we refer to as a targeted therapy, which inhibits the epidermal growth factor receptor tyrosine kinase, blocking that cell signaling pathway. Now, you got to squint a little bit to see the difference in survival between the arms of this study. And if you're looking just at the median or right in the middle, then the difference in survival was only a very modest 2 weeks. But we look at something called the HR, or hazard ratio, which looks at the area between those curves, and that does tell us that it is statistically significant. But it is a modest improvement. The addition of erlotinib does not increase the response rate. It does slightly improve the chance of being around at 1 year. It actually worsens quality of life because it increases diarrhea, and it is very costly. But there was nothing else on the horizon at that point in time. So in 2005, the FDA approved erlotinib in combination with gemcitabine for pancreas cancer. Now, if a drug works only in a small subset of patients, if you can identify a biomarker that might tell you that it's going to work really well in one group of patients, then maybe you'll only offer it to those patients. So in pancreas cancer, we have a mutation called KRAS that confers resistance to EGFR inhibitors, and it's really common in this disease up to 90% of the time. So the group who looked at this drug in the original study looked to see whether those who did not have KRAS mutations might actually benefit more from erlotinib. Unfortunately, that didn't work out. But while KRAS status wasn't predictive of a response, rash did predict it, in that those patients who had the major side effect from erlotinib, which is an acne-looking rash on the face, could actually live longer. In fact, their survival was double if they had a really bad rash. And that led investigators to look to see, well, if you get no rash from erlotinib, if you increase the dose and develop a bad rash, maybe that will help you live longer. Unfortunately, as the Rachel study showed, it actually only increased the rash. It did not increase survival. So it was a good try, but it didn't work. Placing this regimen in context, this trial is important because it was the first randomized trial to demonstrate that any drug added to gemcitabine prolongs survival in this disease. It achieves a statistically significant improvement in overall and progression-free survival with modest toxicity, no improvement in quality of life, and a substantial cost, with no biomarker to select those most likely to benefit, which leads many of us to ask, how clinically meaningful are these results? And is the modest benefit worth the expense and toxicity? It's really not clear to many of us who the best patient for this regimen really is. So over the next 5 years, several more negative randomized trials were reported, and we pancreatic cancer doctors and patients were getting really depressed because we had more and more studies where we had these overlapping survival curves just like this one. Did we learn anything from these negative trials? Well, something called a meta-analysis, where we pull the data from all of the trials, did demonstrate that in those patients who had a good functional status, they could benefit from combination chemo, whereas the very ill patient really benefited only from gemcitabine by itself. And then came the study that changed the way we think about chemotherapy for pancreatic cancer. And that was in 2010, a French trial that randomized patients to either Folfirinox, a 3-drug regimen of 5-FU, irinotecan, and oxaliplatin with the vitamin leucovorin, versus gemcitabine. Here you can see what we call progression-free survival, how long it took before the cancer began to grow. And you can see, you can drive a truck through these curves. Look at how wide the difference is between these two lines, 3.3 versus 6.4 months, with a hazard ratio of 0.47, telling us this is really a meaningful difference. Again, the difference in overall survival was pretty dramatic compared to prior regimens. Looking at the data summarized on this table, we can see that 31% of patients had tumor shrinkage. A total of 70% of patients had either stable or responding disease to this regimen. And we saw median survival of 11 months and 50% 1-year survival. Of course, this came at increased toxicity, including lowering of white blood cells with a risk of fever, diarrhea, numbness and tingling in the hands and feet, and fatigue. Although they had more chemotherapy-related side effects, patients who received Folfirinox still felt much better for much longer than patients who received gemcitabine because the chemo was shrinking and killing their cancer, and that made them feel better. This was a big step forward. After so many negative trials of gemcitabine doublets, the unprecedented outcomes achieved with Folfirinox are a major treatment advance for good performance status pancreatic cancer patients. No other randomized study has ever achieved such a long median survival or demonstrated such a high response rate. And despite substantial but manageable toxicities, Folfirinox also helped patients feel better for longer than if they received gemcitabine, a drug that's used principally because it helps with symptoms. And remarkably, it was even cost-effective. And this was truly a paradigm shift because for the first time, an oncologist can confidently tell a pancreatic cancer patient who has a good functional status that they are very likely to obtain disease control with chemotherapy. Placing this regimen in context, we know that Folfirinox significantly improves median and progression-free survival, yields a meaningful delay in worsening of quality of life, is cost-effective, it is more toxic, so vigilant patient selection, education, and monitoring are essential. So far, there is no biomarker that is identified to date. So who is the best patient for Folfirinox? I'll get to that in a few minutes. because soon afterwards another study demonstrated that another new combination is also more active than gemcitabine. And we pancreatic cancer docs were just doing backflips. We were so happy. And this is the IMPACT trial that compared nab-paclitaxel gemcitabine to gemcitabine alone. This drug is also known as Abraxane. And here again you can see an improvement in progression-free survival and in overall survival, perhaps a little bit smaller than what we saw with Folfirinox, but still statistically significant and clinically meaningful. This table summarizes the effectiveness of this regimen. Here we saw tumor shrinkage in about a quarter of patients and disease control in about half of patients. Of course, it did come at the risk of increased side effects, including lowering of blood counts, such as white cells and platelets, fatigue, and numbness and tingling in the hands and feet. So this trial is important because it was the first randomized study that demonstrated that what we call a cytotoxic agent added to gemcitabine prolonged survival in this disease. This combination significantly improves overall and progression-free survival, although it is a bit more toxic. They did not collect quality of life data prospectively in this study. The retrospective analysis, called a Q-twist, did appear to be favorable. There's conflicting data about cost effectiveness, and a biomarker that was in early studies thought to predict which patient might be more likely to respond, called SPARC, actually was not predictive when it was looked at in this phase 3 study. So who is the optimal patient for Nab-paclitaxel? Well, we're just not accustomed to having good treatment choices in this disease. It's a happy question to have. So between Folfirinox and Nab-paclitaxel, how do we decide which combination is best for which patient? Well, we really need to understand the current data that I just reviewed, as well as its limitations. No biomarker can predict which patient is going to respond to which treatment. It would be really nice. And no randomized trial, unfortunately, compares these two regimens. And while we can look at the data between trials, it's really not as clean as if we were looking at all of the same patients in the same randomized study. So there are a number of factors that we have to take into account when we choose a particular regimen for a particular patient. We really need to understand the data and individualize therapy for each patient. So there are patient-related factors that might affect a doctor's choice of regimen. Their performance status. What other diseases do they have, what we refer to as comorbidity? How far do they live? Do they want to travel once a week or every other week? What's their tolerance for side effects? Do they want the real gentle regimen? Do they want something and are willing to put up with something more toxic? There are regimen-related factors that we look into. What's the response rate? What's the cost? How complex is it? What are the side effects? How much does it improve quality of life? And as doctors, we also look at physician-related factors. A doctor who hasn't given a combination very often, probably more reluctant to give it a try. How good are they at managing side effects like nausea, vomiting, or diarrhea? Things like that are going to come into play. So where are we now for chemotherapy for advanced pancreas cancer? Well, to review, gemcitabine has been the cornerstone of care for many years. It improves quality of life and modestly improves survival. Gemcitabine plus erlotinib marginally improves survival. Meta-analysis suggests that good performance status patients will benefit from gemcitabine plus another drug. Folfirinox improves response, progression-free survival, and overall survival in good performance status patients, as well as improving quality of life. But it is more toxic, and patient selection and monitoring are essential. Gemcitabine plus nab-paclitaxel also improves response, progression-free, and overall survival. It may not be as active as Folfirinox, but it is also less toxic. Although we are making incremental progress in the treatment of advanced pancreas cancer, new drugs and new approaches are still, of course, urgently needed. And unfortunately, there are fewer research dollars allocated to study pancreas cancer compared with other major cancers. Although hopefully, with the help of PanCan and others lobbying the government, hopefully soon, this will be changing soon. And as the first speaker alluded to, January is National Pancreatic Cancer Clinical Trials Awareness Month. So I thought I'd talk to you a bit about clinical trials for this disease. An unfortunate fact is that fewer than 5% of all pancreatic cancer patients enroll in clinical trials. We need to do better than this if we are to advance treatment for this disease. So let me explain to you first the types of clinical trials. So a phase 1 trial looks at dose and side effects. It may be the fresh out of the monkey trial. It may be a drug where we're just trying to figure out, should we test it once a week instead of once every 3 weeks. It is generally offered to patients with any cancer and offered to patients who've had multiple prior regimens, and there is not going to be a placebo. A phase 2 trial, the goal is to determine effectiveness. So in these trials, all patients must have the same cancer, and they must have the same number of prior treatments. You want to compare apples to apples. And so either they're for patients who've never received prior treatment, or maybe they've received either 1 or 2 prior chemotherapies. And the phase 2 trials do not usually have placebos, although some of them are randomized and some of them do. A phase 3 trial compares the new drug or new regimen to a standard regimen. Again, all patients must have the same cancer, all patients must have the same number of prior treatments, and these usually, but don't always, include a placebo. So how do we select new agents to test in clinical trials for pancreas cancer? Well, we start by looking for targets that have intriguing data in the laboratory, although with one caveat that promising preclinical data in mice and test tubes has, of course, led to many disappointing results in patients. Though as we learn more and more about these diseases, hopefully we will have fewer negative trials. And recently, it has been determined that a core set of 12 signaling pathways are genetically altered in most pancreas cancers. And some of these pathways, illustrated here, or their downstream mediators, may be potential therapeutic targets. So how do we select new drugs to test in pancreas cancer patients? So the choice of a drug for a given clinical trial is ultimately based on availability of agents for clinical testing against the target of interest. If you know that XYZ is upregulated in pancreatic cancer, but there's no drug against it, you can't test it in a trial. You then need phase 1 single agent and combination safety data. If drug XYZ has only been tested in monkeys, you have to first test it and figure out the right dose before you then try it in a phase 2 trial in pancreatic cancer patients. And then, of course, there needs to be a willingness on the part of a drug company to test drugs in this disease. So I'm going to go through some types of drugs, and certainly not comprehensive, that are being evaluated for pancreatic cancer, starting first with chemotherapy. So cytotoxic chemotherapy are drugs such as gemcitabine that affect the DNA of the cancer cell in various ways. So one drug that has recently been in clinical trials is MM398. It's called a nanoliposomal irinotecan. It's kind of a cousin of irinotecan, the ERI in Folfirinox. And this drug is actually possibly going to be approved for this disease, probably based upon a randomized study that compared MM398 to either 5-FU, the drug alone, or this drug in combination with 5-FU. And certainly many other studies with this drug, if it is approved, will likely be ongoing. Then there are drugs that enhance the uptake of chemotherapy into the pancreas. These agents target that dense stroma I mentioned earlier around the tumor that acts as a barrier to protect the cancer cells from chemotherapy. So a couple of years ago, we were looking at hedgehog pathway inhibitors. These were drugs that worked beautifully in the lab, but they didn't work so well in patients. Current trials are focusing on agents such as pegylated hyaluronidase, or PEG-HP 20, and that's a drug, again, that tries to enhance the uptake of chemo into the pancreas. And there were some early toxicities with this drug, which hopefully have been overcome. Then there is targeted therapy. These are drugs such as erlotinib that affect signaling pathways that turn cell growth on and off. Now, many early trials of targeted therapy were unsuccessful, likely because they were offered to unselected patients. These drugs may be more effective in subsets of patients who have the specific abnormalities in their own tumors that are targeted specifically by these drugs. For example, patients with BRCA1 and 2 mutations, an inherited type of pancreatic cancer, have abnormal DNA damage repair pathways. And drugs such as PARP inhibitors target these damage repair pathways. There are studies with veliparib in the frontline setting and with olaparib in patients who've received chemotherapy and are then looking at this in the maintenance setting. And there are a few other PARP inhibitors nationally in clinical trials specifically for this subset of patients. Then there's a trial targeting the Janus or kinase, JAK pathway, in patients with something called a high CRP. And here's the drug, ruxolitinib. Then there's immunotherapy, which has become very exciting of late. And we divide those into vaccines, and these are drugs that stimulate the immune system to try to attack the cancer the way a polio vaccine or some other vaccine will do so. And here we've got one randomized study that looks at the GVAX vaccine with CRS-207. This is a 3-arm trial in which patients either get 1 or 2 vaccines or are randomized to standard of care chemotherapy. Then there's a new and exciting class of drug called the immune checkpoint inhibitors. These are drugs that take off the brakes in the immune system so that your body can attack the cancer. There are several agents that are being evaluated in many other diseases that have shown a great deal of promise in other cancers, and they're in fairly early trials in pancreatic cancer. So we really can't judge whether or not they are going to be active, but clearly this is an exciting area of investigation. And hopefully, with studies such as these, hopefully someday, these headlines will be for pancreatic cancer drugs. Thank you very much, and I look forward to answering your questions.
Okay, thank you. And just as a reminder to the audience, you may submit your questions using the Q&A panel located at the bottom right of your screen. Please be sure to address your questions towards all panelists in the drop-down menu. Now I'll get to the first question. This one is, should I enroll in a clinical trial? Are they better than standard treatments?
So, we never know whether a clinical trial is going to be better than standard treatment, but no doctor is going to offer you a clinical trial, hopefully, unless they felt that that clinical trial might offer something better than standard treatment. And the only way we're going to know is to evaluate it in a clinical trial, to evaluate a new drug. And while standard treatments can be good, we are always looking for something better. So that's why we offer patients clinical trials, to try to move the field forward and to try to provide options that can't be available standardly.
Okay, thank you. And we have another one that says, I thought there was never a placebo in cancer trials. This indicated that there may be in phase 2 and 3.
Indeed, sometimes you need to have a placebo in a clinical trial because otherwise you won't know whether it's just in one arm, you just have all of the superstars in a trial, and in the other arm it might be the drug or not the drug. The only way to really know whether, in certain cases, whether a drug is effective is to offer some patients the drug and compare it to patients who are not receiving the drug. Now, in some trials, patients may get one drug, such as gemcitabine, and then they may either get the new drug or a placebo, so they're still getting one drug. In other studies, they may just get the new drug or a placebo. But for certain types of drugs, the best way to study it is to offer some patients the placebo and some patients the standard new drug that the experimental new drug that you're looking at.
Thank you. Another one, should a patient who was resected, Whipple and all the pancreas removed, receive radiation and chemotherapy, or is chemotherapy alone reasonable? It seems that there is a known risk of side effects with radiation and no proven benefits of radiation.
So that's a very good and very complex question. And if you were asking on the other side of the Atlantic, most Europeans would say that chemotherapy alone is sufficient. In the United States, there are many centers that give radiation and many that do not. It really is an open question. And so that is a study of ongoing clinical trials. I don't think it's right or wrong to give radiation. It really needs to be individualized for each patient in a discussion of the options with their physician.
Well, thank you. Now, whatever happens to GTX? Did it ever go to stage 3 trial?
So that combination has been around for quite some time, and it's been evaluated in retrospective series. It's been evaluated in very small phase 2, but it has not been evaluated in phase 3, which is why I did not include that among standard regimens. A lot of regimens have been evaluated in very select phase 2 populations, and they looked fine, and then when they were compared to a standard, they didn't pan out. And so GTX has not been evaluated in combination in a phase 3.
Thank you. And here's another one. Why aren't there any trials comparing Abraxane, gemcitabine to Folfirinox? This seems like a pretty important comparison to make.
Oh, absolutely. Good question. Now, Folfirinox, all of those drugs are off patent and generic. Abraxane is does have a drug company behind it. If you were the drug company, would you want to fund a study that compared your new drug to a combination that might be better? So there's certainly a financial incentive not to do it.
Right. Here's another one we have. Will insurance companies help pay for a clinical trial?
So that partly depends upon your insurance and partly on the state that you live in, because some states have requirements. Medicare patients, I believe, can get that covered under clinical trials, get clinical trials covered under their insurance. In general, clinical trials are designed so that things that would be standard of care regardless, as long as you were getting chemo, you know, your CAT scan, your blood counts, your doctor visits are paid for by insurance, and the new drug and any experimental tests are paid for by the clinical trial. So most insurances will pay for phase 2 and phase 3 trials. The phase 1 trials that are more highly experimental, some insurance companies will not pay. And clearly, clinical trials are essential to moving cancer treatment forward, and I think more lobbying needs to be done to encourage insurance companies to pay for patients on all clinical trials.
And here's another one. Am I correct that many or most of these clinical trials and regular chemotherapy choices are almost based on trial and error with individual patients? Until they are tried, do you not know how a patient may tolerate side effects?
So I'm not fully sure that I understand that question. I think what the person is asking is even if you have data in a whole patient population, you will not know in an individual patient whether something is going to work or not, which is true, and you may or may not know what their side effects are, but you do have enough statistics to know that there is an X% chance that a drug is going to work and that there's an X% chance of certain side effects. And so if somebody has, for example, underlying neuropathy or underlying diabetes, they may be more likely to get a particular side effect than if they don't. And so to a certain degree, it's the doctor's experience with those treatments that helps them be better able to predict which patient might have side effects, as well as their understanding of the data, which helps them predict the likelihood of response. But indeed, there's no guarantee in any patient that they're going to respond to anything or that they're going to have side effects or no side effects from anything.
Thank you. Should I enroll in a clinical trial before or after I try standard treatment?
So most clinical trials for pancreas cancer are first line. That means if you've received no prior chemotherapy. So you have a lot more options in terms of chemotherapy clinical trial choices if you enroll first line. The number of clinical trials for previously treated patients is fewer. And so really, I think it's a good idea to get an opinion from someone, whether it's calling PanCan to find out through their clinical trials database about what trials are available, or going to a center of excellence where the physicians do a lot of clinical trials and treat a lot of pancreas cancer. And it's important when initially diagnosed to see whether there is a clinical trial that might be appropriate for you in the first-line setting. And in any given situation, it might be better for you to just get standard or to get a clinical trial, but you need to know your options first. It's always sad if a patient starts on a chemotherapy and then comes to a center of excellence the next week and finds out that because they started chemo, they're not eligible for a clinical trial until the cancer worsens. And sometimes the cancer worsens enough that they're not healthy enough to go on a trial second line. So always try to get that opinion up front so you have a greater number of options to make your decision.
All right, thank you. Here's another one. Can you tell us more about immunotherapy?
So immunotherapy is an exciting field that's really exploding in many diseases such as melanoma that used to be thought of as diseases where nothing worked are now melting away based on some immunotherapy drugs. The data, again, in pancreas cancer is in earlier stages, so I can't tell you whether or not we will definitely have a future immunotherapy approved for this disease. But certainly if a patient has an option to be evaluated in an immunotherapy trial for pancreas cancer, that would be a very worthwhile thing. Immunotherapy can either be a vaccine where you're trying to immunize a patient against something on the surface of their tumor so that it can be attacked, or an immune checkpoint blockade where the body doesn't recognize your cancer as foreign because there are brakes on your immune system that just say, hey, it's just me. And when the brakes are taken off by these immune checkpoint blockade inhibitors, then suddenly your cancer can be targeted by your immune system to try to be attacked and hopefully melt away. But again, in pancreas cancer, these are in earlier stages but clearly deserve evaluation.
Are there any other factors such as diet and or exercise to enhance survival rates with any of the treatments mentioned today?
So certainly, we have less data in pancreas cancer than we have in other diseases about exercise, but we recently learned in colon cancer that patients who exercise will actually live longer and do better. We know in breast cancer and in other diseases that both exercise and a good diet can certainly be helpful. There are no magic foods. There is no magic diet, but a good, healthy, balanced diet is always appropriate. In pancreatic cancer, many patients have what we call the anorexia-cachexia syndrome, where their bodies are losing weight without trying, and so we clearly want to help patients maintain their weight. And one of the best things for cancer-related fatigue is exercise. So it is very good for patients to stay active to the degree that they can.
Okay, thank you. And we have time for one more question. Have there been any research into alternative therapies such as high-dose vitamin C IV treatment?
I am not an expert in that area, so I really can't tell you whether there have been specific evaluations in pancreatic cancer for high-dose vitamin C. I think that any of these alternative therapies need to be evaluated in formal clinical trials rather than in anecdotal, I'm selling this thing on the internet. So that we can really understand whether or not they offer benefit, but I'm not aware of any randomized studies in pancreatic cancer for that.
All right. The Pancreatic Cancer Action Network would like to thank you, Dr. Kindler, for your presentation today. If you have any other questions that were not answered today, folks, or you would like to get a personalized search of the Pancreatic Cancer Action Network's comprehensive clinical trials database, please contact their Patient and Liaison Services, or simply PALS, P-A-L-S, department at 877-272-6226. Again, that's 877-272-6226. And ask to speak to the PALS associate. Once more, the PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. Real quick, a survey will pop up once you leave the session today. We really appreciate the feedback, so please take a moment to share your thoughts. And that will conclude our webinar for today. Thank you.
Thank you, everybody.